Welcome to TLDR Neuropsychology, where we discuss various topics related to the practice of clinical neuropsychology. We're continuing our series related to preparation for the written component of the neuropsychological board exams. Today's topic is the prominent domains related to neuropsychological functioning. So we're going to cover a definition for what cognition is, intelligence, attention, concentration, and processing speed, language and auditory processing, visual perception, visuospatial and visuoconstruction abilities, memory, executive functioning, sensorimotor abilities, and the emotional and neuropsychiatric domain. For many of these domains, it's hard to describe when they're functioning normally, so various examples of dysfunctions related to each domain will be provided to help clarify that understanding. Neuropsychological evaluations utilize what are called standardized tools to evaluate cognition and behavior. A standardized tool means that they've used the different tools and instruments on a variety of people across different age ranges and different demographic backgrounds. And we generally know what a normal performance and an abnormal performance would look like, whether that abnormal performance be abnormally low or that abnormal performance be abnormally high. And that can give us some insight into what might be going on with various individuals. Behavior is essentially activities in response to internal or external stimuli, and cognition is essentially the mental activities associated with processing, organizing, utilizing information. And a lot of times cognition can drive the behaviors that we display. So cognition includes things like awareness, acquisition of information, storage and retrieval of information, how we mentally organize information, our comprehension of information, whether it's self-generated or generated within our environment, and communication. So these cognitive processes are often organized in various what are called specific neuropsychological domains or constructs. So a construct is a way of categorizing information so that we can better understand human behavior. And as mentioned, it includes things like intelligence, attention, language, visuospatial abilities, memory, executive functioning, our sensorimotor functioning, and our emotional functioning. And these domains are relevant to various what are called neurobehavioral syndromes. So a syndrome is essentially just a set of signs and symptoms that tend to occur together that can indicate a specific type of disorder. As well, other kinds of pathology can influence these cognitive domains. While we often emphasize one or two domains related to each standardized tool, more often than not, they're interacting with multiple cognitive domains. So the first domain we're going to look at is intelligence. Intelligence is often considered our innate general cognitive functioning or capability. So there's no single definition or single way of measuring it. It's often described as including various abilities, things like problem solving, rational thinking, abstract thinking, adaptation to circumstances, goal-directed behavior, reasoning, learning, and our ability to comprehend information. And there's various theories and models to help measure and identify what intelligence is. So we're going to discuss some of the notable intelligence models. So the first model we'll discuss is the Wechsler-Spearman model, founded in 1904. And in general, at that time, what they found was there was this general factor or G factor that appeared to contribute to all of our various cognitive abilities. And this global factor can act as a summary for an individual's cognitive skills. This G factor would be an underlying intelligence factor that would contribute to whatever ability you are able to display throughout your life. This was further elaborated on in the Cattell-Horn-Carroll model in 1993, where they posited that our abilities form a top-down hierarchy with 8 relatively broad intelligence domains and then a variety of other specific abilities. So for example, your ability to define words would be one of those specific abilities, and that would contribute to an overall verbal intelligence domain. Whereas your ability to accurately draw a picture would be a different specific ability, and that would contribute to a visual spatial general domain. And general intelligence contributes to all of these different domains, or the G factor. These broad intelligence domains include fluid intelligence, which is the ability to think abstractly and reason through problems. Crystallized intelligence, which essentially represents knowledge that we gain throughout life. General memory and learning. Broad visual perception, so your ability to accurately see and manipulate visual information. Broad auditory perception, so your ability to accurately hear and manipulate auditory information. Broad retrieval ability, so that includes the ability to retrieve information accurately. Broad cognitive speediness, so that's how quickly you can process information. And finally, our ability to quickly make decisions or react quickly. Another model of intelligence is the G verbal perceptual rotation, or GVPR model from 2005. So this has a 4-stratum hierarchy with what are called primary traits, and then broader but still relatively narrow abilities, then verbal, perceptual, and rotational factors, and on top of that is the overall G factor. So a primary trait could be something like your understanding of phonemes when it comes to words. And then that would contribute to a narrow ability such as either reading ability or your ability to define words. And that's related to the verbal factor, which in turn is related to the overall general intelligence factor. Thus far, these 3 different models all relied on the same technique to come up with these different factors. They used a factor analysis strategy. There are some different details about how the factor analysis was conducted, which resulted in some of the different findings. But the Wechsler, Cattell-Horn, Carroll, and GVPR models all utilize this technique to isolate this G factor as well as the different hierarchical factors that contribute to their models. In 1983, Gardner proposed a theory of multiple intelligence. According to Gardner, there are specific modalities of intelligence with weak relationships between them. This idea of multiple intelligences is a somewhat popular idea. So examples would be like musical intelligence would be different from body kinesthetic intelligence, which would be different from your language intelligence, which would be different from your painting or artistic intelligence. There are some pretty significant criticisms for this model, though. First, there hasn't really been empirical support for this model, and a lot of the times it lacks what's called falsifiability. So there's no way to prove it wrong with scientific experimentation. Also, contrary to what's predicted by Gardner's model, research finds that there is a strong correlation between the different aspects of intelligence. So it's not a weak relationship between people's sets of abilities. Additionally, a lot of the specific intelligence modalities were determined subjectively. There's no systematic way that those were identified and measured. So there's an arbitrariness to the modalities that he identified. Another intelligence model is Sternberg's triarchic theory of intelligence from 1985. And for Sternberg, intelligence was defined as how well an individual deals with environmental change throughout their lifespan. And he identified 3 components for intelligence. The first he called the componential aspect, which essentially means the analytical aspect, your ability to analyze changes in your environment. So you're breaking down problems, generating innovative solutions, those kinds of things. The second was the experiential, creative aspect of intelligence, and that's your ability to manage novel situations in innovative kind of ways, or completing repetitive tasks in a more automated type of manner without really having to think a lot about it. And the third component was the practical, or also called contextual. And that's your ability to adapt to your surroundings or shape the environment to better suit your needs, or selecting a new environment to reach personal goals. This model has also been criticized for a lack of empirical support. Another popular concept is the idea of emotional intelligence. This is considered to be the ability to perceive, process, understand, and control emotions within yourself and within others. There's a lot of controversy related to emotional intelligence. Multiple meta-analyses have shown that the effects of emotional intelligence go away after you start accounting for things like self-rated self-efficacy. So that's essentially a self-reported belief about an individual's capacity to do the things that they need to do. Also, if you control for self-rated performance, as well as aspects of personality, particularly related to neuroticism, extroversion, and conscientiousness, and overall IQ. It's also been argued that emotional intelligence is not another form of or type of intelligence, but an application of intelligence. Another related concept is called theory of mind, and this is the ability to make inferences about other people's intentions, motivations, and emotional states. And it's something that is often considered in deficit in certain disorders, such as autism spectrum disorder. So there's a few disorders that are associated with intelligence. The first we'll talk about is intellectual developmental disorder, or intellectual disability. And essentially, those individuals have an IQ score that's 2 standard deviations below what would be the middle of the normal range, and they have deficits in 2 or more of what's called adaptive skill domains. So that includes their ability to conceptualize information, their social functioning, as well as their ability to practically care for themselves. And the age of onset has to be before 18 because it's a developmental disorder, so it has to occur during development. If individuals demonstrate these difficulties after the age of 18 or following some kind of injury, then it wouldn't qualify for an intellectual developmental disorder. Savantism is somewhat related to intellectual disability, and this is a rare syndrome where an individual with an intellectual disability demonstrates one or more specific exceptional abilities. So this can include things like having an exceptional memory or ability to calculate numbers, solve numerical problems. Some people demonstrate incredible knowledge of the calendar or amazing artistic abilities or language abilities. And savantism has often been associated with autism spectrum disorder. Dementia is another type of disorder that's often associated with intelligence. Dementia is a non-specific term, so there tend to be a few different syndromes or disorders that would all qualify as dementia, depending on an individual's specific presentation. So dementia is characterized by a decline in general cognitive ability or multiple areas of cognitive impairment, and it often impairs social and/or occupational functioning. What's found is that for these dementing neurodegenerative disorders, IQ continues to decline as the disease progresses. Although often this decline isn't noticeable until you start getting to the middle or later stages. And this is particularly true of Alzheimer's disease. So the next domain we're going to talk about is attention, concentration, and processing speed. So attention is the process by which people receive and meaningfully filter, organize, and utilize information. It's closely tied with perception, executive functioning, and memory, particularly the more limited working memory, which is essentially just information that's been somewhat processed before it gets sent to short-term memory or longer-term memory stores. And working memory has to be actively maintained. For example, if you're learning a list of words, you'll often repeat the list of words back to yourself, which is called rehearsal. And that helps you retain that list of words for several minutes. The information that enters working memory is often lost when it's not rehearsed or you're manipulating it in some way. Concentration is considered the ability to sustain attention over time or to mentally manipulate information over a period of time. And processing speed is the speed at which we can perform different mental activities. And it contributes to our overall cognitive efficiency as we're processing information. Attention can be broken down into different components. Simple attention is a voluntary, limited capacity type of attention to retain information that often goes directly into working memory. So if that information is not rehearsed or reinforced in some way, then it's often lost. Focused attention is your ability to allocate and direct your attention independent of overall attention capacity. Selective attention is choosing information from other surrounding information or distractors. So that would be if you had to find a certain letter on a page of different letters, you would use your selective attention to pick out the letter you're looking for. Sustained attention also includes vigilance and concentration, is maintaining your attention over periods of time. Alternating attention is being able to switch your attention back and forth between tasks. So this frequently occurs while driving. Divided attention is also somewhat related to alternating attention, and that's your ability to concentrate, so maintain that attention over periods of time on more than one task, or a task that has multiple components, and it's often called multitasking. So our attention is divided while we're driving, or if you're working on something while watching TV. All of that is reliant on your ability to alternate and divide attention. Posner and Peterson developed a neurobiological model of attention, and they indicated that there's interconnected posterior, anterior, and alerting networks that contribute to our attentional abilities. Posterior components are involved in orienting and shifting attention. The anterior component of attention is involved in the detection subsystem, also called the executive attention subsystem. And this allows us to detect and select information from sensory events or memory. Alerting helps modulate our levels of physiological arousal and influences the other two attention networks. And this chart talks about some of the important brain structures and what components of attention they contribute to. And I'm not going to read through all of them, but you can see that there's a variety of neurological systems that play an important role in attention. And a lot of these systems are spread out through much of the brain outside of some of the specific cortices. For example, the ascending reticular activating system travels up through much of the brain stem, and that keeps us alert and aroused. If there's dysfunction there, then you're likely to fall into states of unconsciousness. And you can pause and look over this chart as needed. Here's some more brain areas that are relevant to attention. The thalamus and midbrain have three areas that all contribute to attention. So for example, the pulvinar nuclei extract spatial information and filter out distracting information. The colliculi play an important role in allowing us to orientate either with our eyes or orientate to information with our ears. And the right hemisphere as a whole plays an important role overall in spatial attention and appreciation of the whole of things, or what's called the gestalt. And once again, you can pause the video to look over this chart in more detail. One critical point to understand about attention is that it's a non-specific symptom. For example, other non-specific symptoms include things like headaches. So a headache could mean that you have a tumor growing within your brain, but it also could mean that you're dehydrated. It could also mean that your muscles are a little tense. It could also mean that you're excessively fatigued. So just having trouble with your attention doesn't necessarily mean that you would have a specific attentional disorder like ADHD. There could be a lot of other things that are causing the attentional disruption. And attentional disruption is the most common cognitive impairment following any kind of brain injury or illness. You've probably noticed that when you have a cold, it becomes a lot harder to focus on things. Additionally, people often describe attention-related problems as memory problems. This is because functioning attentional abilities are foundational for the later memory aspect of things. So what ends up happening is people often miss the first step of memory, which is encoding information, because their attention is so scattered. But if you give them appropriate time to encode that information, then a lot of the times they can recall that information relatively easily. So there's a few disorders that are associated with attention. Delirium is a disorder that's marked by deficits in attention, including things like increased distractibility, poor awareness, and persistent confusion. Individuals with delirium also demonstrate disruptions to arousal, so they're not always alert or awake, as well as overall attention span. So it's hard for them to sustain attention over time. Attention deficit hyperactivity disorder, or ADHD, is a developmental disorder with features that include things like inattention, impulsivity, and hyperactivity. And there's often disruptions related to sustained attention and the executive aspects of attention functioning. So things like self-regulation or organizing information in usable components. An important thing to note about ADHD is that it's, once again, a developmental disorder. So for that disorder to be diagnosed, the deficits need to appear during development, so before the age of 18 roughly. Other disorders associated with attention include hemispatial inattention or neglect. This is commonly found following a right hemisphere brain injury. So this includes impairments in awareness of the visual hemifield. Hemifield would be either the temporal or nasal side of your vision. And this isn't caused by deficits in your actual visual abilities. So if you look at the clock drawing to the left, you'll see that all of the numbers are on the same side of the clock, which would indicate that there is hemispatial neglect occurring. Additionally, down below is a letter search, and you see that they've identified all the letters on the right side of the page, but the left side of the page is unmarked, which once again would indicate this hemispatial neglect. Hemispatial neglect can also include symptoms of where you're denying illness, which is called anosognosia, or denying that certain body parts exist, usually on the half of your body that's opposite of where the injury is located, or asomatognosia, and what's called extinction of stimuli, where people stop responding to stimuli on the side where they're experiencing the neglect. So hemispatial neglect is often associated with lesions in the temporal parietal areas, particularly along the right hemisphere. You'll see left hemispatial neglect or contralateral hemispatial neglect. And they've found that hemispatial neglect has underlying disruptions to spatial focused attention as well as selective attention. And hemispatial neglect is considered a type of sensory neglect, which is acquired inattention or unawareness of part of space opposite to the side that the lesion is on. There's also motor neglect, which is characterized by failing to respond or initiate movement in response to stimuli, called akinesia. Or it can present with a combined sensory and motor neglect, where you're ignoring both stimuli and demonstrating reduced movement opposite to the side of the injury. So you'll see a lot of disruption to attention following traumatic brain injuries, which are mechanical injuries to the brain that disrupt brain functioning. And following these traumatic brain injuries, you can see deficits in things like arousal, you can see poor attentional capacity, distractibility, reduced information processing speed, and a disruption to the ability to organize and direct attention. This attention disruption is most common in moderate to severe traumatic brain injuries. Mild traumatic brain injuries or concussions can temporarily disrupt things like working memory, attention, and processing speed. But typically, individuals will recover from those deficits following a mild traumatic brain injury within 3 months. Whereas for individuals who have sustained a moderate to severe traumatic brain injury, there may be persistent deficits despite rehabilitation efforts. Other disorders that disrupt brain structures and white matter integrity can also disrupt attention, so that includes things like MS or multiple sclerosis, strokes, or not getting enough blood to your brain. That can disrupt attention. Parkinson's disease is characterized by deficits in attention, and psychosis, those kinds of things. And there's a variety of other factors that can affect attention. So this includes general mood. So if you're depressed or anxious, that will disrupt your attention. And a lot of the times, particularly for depression and anxiety, you end up focusing excessively on either the negative aspects of your life or the thing that's making you anxious, which can be adaptive if it leads to action to correct those areas. But if it's out of control and it's overwhelming, then it might not be helpful for you in the long run. And it might take additional intervention or psychotherapy to address those concerns. Fatigue plays a big role in attention. You've probably experienced that after a long day of work, it becomes a lot harder to focus on the things you're trying to do. Sleep disturbance, so if you're sleeping poorly, your attention is going to be disrupted. Low arousal, so if you're just low energy, almost in a state of sleep, your attention is going to be disrupted. Environmental factors, so if it's really noisy in your environment or overstimulating, that can disrupt your attention. Also included in environmental factors would be some of the physical items that prominently draw our attention because of their stimulating effect on us. That includes smartphones, which are often used to endlessly scroll without purpose on social media apps. Another important factor that can impair attention is if you're feeling sick or ill. That's probably something that we've all experienced, that we're not able to focus as well when we're under the weather as when we're feeling healthy. This contributes to the idea that our physical well-being is our mental and cognitive well-being. Finally, various medications can either impair or enhance our attention depending on the dose of the medication, the type of medication, and what neurological systems it impacts. So for example, a lot of cold medications, things like NyQuil, can facilitate drowsiness, which can help people fall asleep easier at night. Whereas other medications, such as Adderall or Concerta, are specifically designed to work on cognitive systems to help individuals who take them focus better. And finally, the last factor that often impacts our attention is just generally having a low motivation or putting in low effort into the tasks that we're trying to engage with. Often we get motivation backwards. We think that we feel motivated and then we perform a task, whereas I think more often than not, you start performing the task and then the motivation comes to continue performing the task as you work through it. The next cognitive domain that we're going to discuss is language and auditory processing. Language is considered a general system of communication. It involves a formal, symbolic organization and includes things like phonology, syntax, semantics, pragmatics, all in an effort to express meaning. So phonology is the underlying speech sounds and rules underlying the production of those speech sounds. Syntax includes rules governing the structure of phrases and sentences. Semantics is about the meaning of words and the rules governing the use of those words, so putting the correct sequence of words to produce that meaning. And pragmatics is the general context in which words are used. Speech is a physical expression of language, and it can be either vocal or gesticulatory, such as with sign language. So there's separate neurological tissues related to both expressing and receiving language. We discussed these briefly in the episode about functional neuroanatomy. So expressive language is typically controlled by the anterior parts of our brain regions, so more forward in our head, whereas the receptive language areas are typically more in the posterior parts of our brain, but not so posterior as to overlap with the visual cortex. The left hemisphere is typically the language dominant hemisphere, which means that's where a lot of the language processing occurs. And it's particularly related to the aspects of semantic and syntactic parts of language. The right hemisphere mediates what's called prosody. So prosody is things like intonation, stress, and rhythm while we speak. If prosody is disrupted, people may sound like they're talking robotically or in a monotone, and they often lack the emotional inflections that typically occur while speaking. There's a few different categories of language disorders. So aphasia is probably the most prominent one, and it's an acquired loss or impairment of language following either brain injury or some kind of brain disease. There's other developmental or non-aphasic language disorders, and that's typically language impairment secondary to some kind of disruption to developmental processes. Examples of those include things like dyslexia, what's called apraxia of speech, and dysarthria. When it comes to assessing aphasia, there's some key aspects of language to think about. One is, how is the person's spontaneous speech while you're conversing with them? What's the form of their speech like? Is it taking a lot of effort to produce the speech? Is their speech atypical? Are they talking excessively fast or excessively slow? Is there a melody to their speech? Are the length of their phrases variable, or are they only giving one or two word answers? And this can help indicate whether they're speaking fluently or non-fluently. Additionally, you want to look at the content of their speech. And you can evaluate that by noticing their word choice, the overall syntax that they're using when they speak, and the presence of what are called paraphasic speech errors. So that includes using an incorrect sound in the middle of a word, or substituting the wrong word in for a more appropriate word. Another important aspect of speech when evaluating aphasia is the overall comprehension of both spoken and written language. And that can be evaluated by having the individual respond to questions and commands, seeing if they're responding appropriately or inappropriately, testing their vocabulary knowledge, as well as what's called category-specific information. So if they have a good understanding of letters, can name colors, name body parts, those kinds of things. Finally, and probably the easiest to notice, is if there are any errors imparted from syntax and word order. If the things that they're saying actually make sense as they're saying them. So these comprehension difficulties can either be what's called syntactic, which is more associated with some of the anterior speech areas, or lexical or semantic, which is more associated with posterior speech areas. Another important area to evaluate when it comes to aphasia is repetition. This can be evaluated by having them initially repeat just simple words, and then multisyllabic words, followed by short sentences, and then more complex sentences. You can approximate the location of injury and aphasia based on the performance of individuals on these various tasks. Other aspects of language relevant to the assessment of aphasia include naming, which is evaluated by naming objects, colors, body parts, or if they display things like word-finding difficulties during spontaneous speech, so where there will be long pauses or trouble providing the right word as they're talking with them. Naming difficulties are often described as either anomia or dysnomia, which can be trouble naming or retrieving known words. This can also show up as what are called circumlocutions, which is using an excessive number of words to describe something. So one way to think about it is they talk around the word that they're trying to describe. Reading is another skill that can be impacted by aphasia, and this can be evaluated by having them identify letters, numerical digits, words, or other increasingly complex sentences. And often you'll want to test both oral and silent reading comprehension. And when this is impaired, it's called alexia, or impairment in reading, unrelated to a simple sensory or motor problem. If you know that they have difficulties with expressive language, you can facilitate evaluating reading by having them do word matching tasks or responding with pictures to identify the appropriate word meaning. Writing is another area that's important to evaluate. Just have them write letters, individual digits, words, multi-digit numbers, as well as sentences of different lengths and complexity. And you'll want to test both when you're dictating the stimuli to them, as well as just having them look at a page with the stimuli on it and write that. And when there's an impairment in this writing ability, it's often called agraphia, or loss of ability to write. And this typically occurs in combination with alexia or aphasia. So it can occur on its own, but it's more likely to occur with other compounding language-related difficulties. These charts show how some of these skills relate to identifying different aphasic syndromes. For example, Broca's aphasia is characterized by non-fluent speech with intact comprehension, repetition is impaired, naming is often limited, reading is often limited, and they display impaired writing that's consistent with their speech. They're able to write, but it's shorter phrases, and it's often very effortful. That contrasts with Wernicke's aphasia, which demonstrates fluent speech, but the comprehension is impaired. And this fluent speech is often not very meaningful. And you can see repetition is impaired for individuals with Wernicke's aphasia, as well as naming, reading, and writing. I'll just go through one more of these, which is conduction aphasia, where individuals display fluent speech with intact comprehension, but you'll see that deficit in repetition and naming. Reading will also be intact, but writing will often be impaired. And conduction aphasia is caused by a disruption of the arcuate fasciculus, which connects both Wernicke's and Broca's areas in the brain. Here's some other types of aphasia that individuals can present with. So if, for example, a subcortical aphasia is typically due to damage in subcortical areas, and it can be either fluent or non-fluent. Comprehension can be intact, repetition can be intact, but naming is often impaired. And then reading or writing may be intact or may be impaired depending on the specific subcortical areas that are damaged. Some of the transcortical aphasias have some interesting presentations. So there's motory and sensory transcortical aphasia, or mixed, which is kind of a combination of the two. And once again, some of the key differentiators between a motor and sensory transcortical aphasia is whether it's fluent or non-fluent. Although for sensory transcortical aphasia, they often display what's called echolalia, which means they'll repeat certain sounds or syllables or short phrases over and over again after you say them to them. There's some comprehension differences between motor and sensory transcortical aphasias, as well as differences in naming and reading ability. We're just going to briefly review some of the general neuroanatomy when it comes to aphasia. Fluent aphasias are typically caused by dysfunction in the posterior language areas, including much of the temporal lobe. Non-fluent aphasia is often caused by dysfunction in the anterior language areas, which are typically part of the frontal lobes. And then aphasia without repetition dysfunction is often due to dysfunction along what's called parasylvian areas. So if you look at the graphic to the right, much of the colored in area that you'll see are what are considered parasylvian areas. And the sylvian fissure is what separates the frontal lobe from the temporal lobe. So you can see the line running through about the middle of the colored in area, which would be the sylvian fissure. When you get language dysfunction with repetition dysfunction, that suggests dysfunction along some of the border zones of the language areas. The extent and persistence of aphasic deficits are directly related to how big the lesion is and where the lesion is located. So most of the improvements in language abilities following aphasia occur within the first few months following the injury, which is why it's very important to be engaged during the rehabilitation process with physical therapy, occupational therapy, as well as speech and language therapy. Stroke is probably the largest cause of aphasia, and cortical strokes typically have better outcomes than subcortical strokes because the effects of cortical strokes tend to be more focal than the effects of subcortical strokes, because subcortical strokes can disrupt the connections between a variety of areas throughout the brain. And the most damaging types of strokes include both cortical and subcortical structures. So there's different ways of classifying aphasia syndromes based on the neuroanatomical dysfunction. One way of organizing aphasias is what are called parasylvian aphasia syndrome. In the graphic to the right, there's the lateral sulcus, also called the sylvian fissure. And these aphasic syndromes typically occur as a result of disruption to areas around that sulcus. They often display impaired repetition. They can be both fluent or non-fluent, and it includes things like Broca's aphasia, Wernicke's aphasia, and conduction aphasias. There's extrasylvian aphasic syndromes, which means beyond the areas right around the sylvian fissure. And in these, repetition is often preserved with distinct language impairment. And once again, these can be fluent or non-fluent, and these include the transcortical aphasias. There are also non-localizing aphasic syndromes, and these include anomic aphasia, which is characterized by word-finding difficulties and circumlocutions, and disruptions to reading and writing with intact repetition and comprehension. And this is often a residual disorder as other types of aphasic injuries recover. There's also global aphasia, which is a severe disturbance to all major language functions. And this typically occurs as a result of a stroke near the beginning of the middle cerebral artery. So if you look at the graphic down below, this shows the blood supply zones of the anterior, which is in blue, posterior, which is in yellow, and middle cerebral arteries. So you can see if you get a blockage to the middle cerebral artery, there's a large area that includes much of our language areas that will be injured by that blockage. So another classification based on neuroanatomical dysfunction for aphasias is subcortical aphasia syndrome. And that's typically from lesions to part of the basal ganglia called the striatum, as well as the internal capsule and the thalamus. And these can also be fluent or non-fluent. So we're going to move past aphasia and talk about other language syndromes. Alexia is a type of language disorder where someone is unable to read, and that can occur with or without what's called agraphia, which is people's ability to write. In cases without agraphia, you can't read any kinds of configurations of letters, but you're able to write and you don't display any other kinds of significant language disturbances. When agraphia is included, you lose both the ability to read and write despite intact motor abilities. And speech and comprehension may also be intact in these individuals. That said, naming difficulties or anomia can be present as well. Pure word deafness is another language syndrome that individuals can present with, and it's the loss of auditory comprehension of speech, despite their speech, reading, and writing being intact. These individuals are also unable to repeat phrases. There's also non-language auditory processing syndromes. So auditory agnosia is one of these. So there's agnosia for sounds, which is the inability to recognize the meaning of nonverbal environmental sounds. So that could be the sound of a train whistle, you wouldn't be able to identify it, or if a dog was barking, you wouldn't be able to identify it. And it's often associated with pure word deafness. And it's related to disruption of the bilateral primary auditory areas. Additionally, there's agnosia for music, also called amusica, where you don't have the ability to recognize the meaning of various musical sounds. You can't really appreciate or understand rhythm. And for these individuals, musical sounds are no different from noise. And this is associated with right or bilateral damage to the temporal lobes. There's also aprosodias, such as expressive aprosodia, where you have the inability to convey inflection and tonal qualities of emotions. So you speak with somewhat of a robotic voice. And this is often due to lesions in the right hemisphere that are analogous to Broca's area, which would be that frontal parasylvian part of the right hemisphere. There's also receptive aprosodia, where individuals have difficulty interpreting emotional prosody, rhythm, pitch, stress, intonation, etc. when other people speak. And these individuals typically have difficulty recognizing things like sarcasm, cynicism, jokes, and other types of idiomatic speech. And this is often due to a lesion in the right hemisphere analogous to Wernicke's area, which would be a temporal parasylvian injury within the right hemisphere. The next domain that we're going to discuss is visual perception, visual spatial abilities, as well as visual construction. So visual perception is defined as the cognitive ability to receive, recognize, interpret, and act upon visual stimuli. This enables the recognition of objects based on their form, pattern, and color. Visual spatial ability is the ability to identify, integrate, and analyze space and visual form, details, structure, and spatial relations. And this can include cognitive manipulation of visual information. And visual construction is the ability to organize and manually manipulate spatial information to make a design. So this involves coordination of motor and spatial skills. Remember that there are two visual streams, or two pathways along which visual information travels. So one is the ventral stream, or wet stream, and that's used for identifying and analyzing and integrating specific characteristics of visual stimuli, things like color, form, etc. And that projects through occipital temporal association cortices. And dysfunction is associated with visual agnosia, the inability to recognize various objects. And this can be evaluated with what are called gestalt tests. So if you look to the right, you'll see different shapes that have pieces broken out of them. A gestalt test would be to be able to identify the overall shape despite the pieces that are missing. If you have visual agnosia, you won't be able to identify the shape on the left as a circle and the shape on the right as a rectangle. The second stream is the dorsal stream, or where stream. And that's involved in visual processing to analyze the locations of objects within the environment. And these project through the parietal occipital association cortices. And dysfunction is often associated with spatial processing impairments. These can be evaluated with spatial judgment or orientation tasks. One common spatial judgment task would be to draw different sized lines on a page and have the person try and draw a perpendicular line through the middle of that line. There's another proposed visual stream called the superior temporal sulcus system that would be our ability to analyze objects and or body parts when they're in motion. But there's not nearly as much evidence for this proposed system as there are for the other two streams. Now we're going to discuss some of the disorders that happen when there are deficits or disruptions to our visual perceptual, visual spatial, and visual construction systems. So visual agnosias are acquired disorders resulting in the inability to recognize formerly familiar objects that aren't due to other kinds of cognitive abilities or just lack of familiarity with the object in question. So you can have a visual object agnosia, where you have the inability to visually recognize and appreciate the meaning or character of an object. This can be further broken down into apperceptive agnosia, which is the inability to perceive visual objects. So you don't have the ability to copy or draw objects, and you can't match or sort objects into categories. There's also associative agnosia, where people don't have the ability to recognize visual objects. So you can't name or demonstrate the object's use, but you can match and draw the objects accurately. Another specific type of visual agnosia is prosopagnosia, or the inability to recognize, identify, or revisualize a face, regardless of if the face is familiar or unfamiliar. So there's a famous book that discusses this topic as well as other ones called The Man Who Mistook His Wife for a Hat. It's a very interesting book that's well worth reading. The specific story that formed the title, the man has prosopagnosia and is unable to identify his wife's face. So these individuals can recognize speech, gait patterns, and other personal details to help identify the other person, but they can't identify the person based on their face. And this is typically due to bilateral damage in ventral inferior occipital temporal areas, particularly an area called the fusiform gyrus. There's also color agnosia, which is the inability to recognize colors despite intact ability to discriminate between colors. Now we're going to talk about impairments in spatial analysis and processing. These kinds of impairments often lead to what's called constructional apraxia, which is impairment in the ability to carry out purposeful movements to construct shapes or geometric designs and arrange blocks into specific patterns or designs based on the task. A subtype of constructional apraxia includes dressing apraxia, which is an isolated disturbance in people's ability to dress themselves, and it may be part of a hemispatial neglect syndrome, where they're able to dress one side of themselves but not the other side. There's also achromatopsia, which is impairment in color perception, where individuals can only see things in black and white, and it's often associated with occipital and temporal lobe lesions. And it's usually restricted to what's called a hemifield or a quadrant. And if you look at the graphic on the right, you can see representations of the different visual quadrants for each eye, and a hemifield would be either the temporal or nasal two quadrants of our overall visual field. Spatial acalculia is another type of impairment that can occur, and that's a deficit in our calculation ability due to spatial confusion. And these individuals have difficulty processing the spatial aspects of different word problems, and it's associated with injury to the right hemisphere. The next cognitive domain we're going to discuss is related to memory. Memory is defined as the process of encoding, retaining, and retrieving information. Functional perceptual as well as attentional processes are necessary for memory and learning to occur. If there's damage to your attention, you're not going to be able to effectively encode the information that you're being presented. And memory is considered to be diffusely distributed through the brain tissue with a lot of different relevant structures for memory functioning and formation. So memory is often conceptualized in multiple aspects. One model to conceptualize this is what's called an information processing model, where you have encoding, which is the active organization or manipulation of incoming stimuli, storage, which is the transformation of some of the shorter-term transient memory to a more permanent memory store. As things are going into storage, they go through what's called consolidation, which is a variety of cognitive processes that help transform encoded information to a more stable and permanent memory. And finally, retrieval is the ability to recall previously stored information. And retrieval can be broken down into free recall, which is remembering information without any kind of cueing, or recognition, which is when you cue people to facilitate the recall of information. And a memory cue is any kind of stimulus that aids in this retrieval process. Another conceptualization for memory is what's called the three-stage model. The first stage is what's called sensory memory. These are brief stores of information that last about 1 to 4 seconds that represent specific sensory interpretations of our environment. Then there's short-term memory, which has a limited capacity, which is plus or minus 7 items, and it's temporarily stored information that lasts for a few minutes. And finally, there's long-term memory, which is a more permanent storage, which can be retrieved volitionally. And it's thought that a process of long-term potentiation occurring in the hippocampus helps facilitate our long-term memory. Long-term potentiation being ways that neuronal cells alter their functioning. And within this three-stage model, there's also what are called remote memory, which are very old memory and presumed to be more stable and resilient to damage or disease. So for example, remembering your name or childhood address tend to be some of these remote memories that are very stable. Another valuable conceptualization of memory is breaking memory down into different types of memory based on the information that's stored. So one type of memory is what's called declarative or explicit memory. And these are memory systems related to volitional retrieval or recognition of information or episodes. So if you're remembering a story from your childhood, that would fall into this kind of declarative memory. Or if you're remembering the date that the Pilgrims arrived in North America, that would also be a type of declarative or explicit memory. And this can be broken down into what's called semantic memory, which is knowledge of facts, which would be historical dates or historical information, as well as episodic or autobiographical memory, which would be knowledge of temporal events that you were involved in. Episodic memory includes a variety of aspects, including source memory, which is knowledge of when and where you learned something, as well as prospective memory, which is remembering to do something at a future time, and that often involves our frontal executive abilities to organize that information so that we can remember it in the future, as well as temporal order memory, which is remembering the order in which events occurred. There's also non-declarative or implicit or procedural memory, and this is memory related to skills, procedures, habits, and other learned automatic responses, such as responses that are classically conditioned. And these ones don't require conscious awareness. So an example of this would be knowing how to ride a bike or being able to juggle. And there's metamemory, which is knowledge about your own memory functioning. Another important concept related to memory is called memory interference. So one is retroactive interference, where newly learned information interferes with your ability to accurately recall previously learned information. And proactive interference, which is when previously learned information interferes with your ability to recall newly learned information. There's also a memory dysfunction called confabulation or honest lying, and this is characterized by the production of fabricated or distorted or misinterpreted memories without the intent to deceive. So this is common in Wernicke-Korsakoff syndrome, wherein due to thiamine deficiency, damage occurs along the memory system, and these individuals have difficulty accurately relaying stories. They often believe the things that they're saying. If you talk to someone else who was there for the event that they're recalling, the memory is often grossly inaccurate. And it's frequently characterized by misremembering autobiographical information. There's an episode of House where he is working with someone who presents with confabulation, where he walks in with a clipboard with a picture of a Ferris wheel on it, and when he's talking to the individual, the patient starts describing what happened as if her injury occurred on a Ferris wheel. As far as the neuroanatomy of memory goes, remember that there's two different relevant circuits, the medial limbic circuit and the lateral limbic circuit, and this is a depiction of the various structures that are involved in memory functioning and how they connect with each other. And for more information, once again, you can refer to the neuroanatomy lecture. We're going to review some of the amnestic conditions that are associated with dysfunction when it comes to memory. So there's retrograde amnesia, which is the inability to recall events prior to an accident, illness, or event. And related to this is what's called Ribot's law, which indicates that the oldest memories are the most resistant to amnesia. Things like your name or childhood phone number tend to be fairly resilient in comparison with whatever you learned last week. And there's an association between the extent of hippocampal pathology and the severity of retrograde amnesia when it occurs. There's also anterograde amnesia, which is the inability to learn or encode new information. One common type that you'll see in medical settings is post-traumatic amnesia. The length of this amnestic period can be used to predict or indicate the severity of a traumatic brain injury as well as long-term outcomes. Global transient amnesia is another type of amnesia, which is acute onset memory loss, which typically resolves within 24 hours and is characterized by profound anterograde amnesia and variable levels of retrograde amnesia. And individuals with GTA often present with confabulation. The underlying cause of GTA is not clear, but neurologically it's associated with hyperperfusion of the medial temporal lobe and diencephalic areas, and is thought to be represented by a disconnection of the lateral and medial limbic circuits. Typically, these individuals are alert and oriented to self. Another amnestic condition is functional amnesia, also called psychogenic amnesia or fugue. And this is amnestic presentation due to a psychiatric etiology or trauma rather than caused by a physical injury. There's also functional amnesia, also called psychogenic amnesia or fugue, which is typically due to a psychiatric etiology or trauma rather than caused by a physical injury. And this presentation typically deviates from Ribot's law, where they have retrograde amnesia with the loss of some of that early autobiographical information. So they'll forget their name or their home address or other information that is typically preserved following a physical injury to the brain. Another type of amnesia is infantile amnesia, which is the inability to recall autobiographical information from early childhood, usually before the age of 3 or 5. There can also be drug-induced amnesias, which are temporary memory loss caused by certain drugs. It's fairly common following the use of Ambien or other kinds of DADAR drugs. There are some particular conditions that commonly cause amnesia, so these include anoxia or hypoxia, which is a loss or reduction of blood supply to the brain. These types of injuries commonly damage the medial temporal lobe, particularly the CA1 part of the hippocampus. They find that if you also sustain damage to the lateral limbic circuit, then the memory loss will be much more severe. That said, insight is generally preserved and confabulation is rare in these cases. Another common cause of amnesia is anterior communicating artery aneurysm, and this type of injury typically damages the basal forebrain, as well as the basal ganglia, particularly the striatum, as well as frontal lobe systems. And this disrupts the cholinergic projections, or the neuronal projections that typically release acetylcholine, in the medial and lateral limbic circuits. And these frontal amnesias are characterized by confabulation, attention difficulties, disorientation, reduced insight and motivation, increased sensitivity to proactive interference, which means that older information is interfering with their ability to learn new information, and a varying degree of retrograde amnesia. Other conditions that commonly result in amnesia include, as mentioned before, Wernicke-Korsakoff syndrome. It's caused by vitamin B1 deficiency or thiamine deficiency. And this is most commonly seen as a result of chronic excessive alcohol use. And this deficiency disrupts diencephalic brain structures. And these individuals present with both retrograde and anterograde amnesia, proactive interference for learning, so old information interferes with new information, trouble remembering the temporal order of events or information, confabulation, generally poor insight, what's called gait ataxia, so they present with an uncoordinated, staggering gait, oculomotor palsy, which is a reduced ability to move your eyes, and encephalopathy, which are changes in the brain structure or functioning. Herpes encephalopathy is another common cause of amnesia, which is the result of infection with the herpes virus, which disrupts functioning in the amygdala and medial and inferior temporal lobes. And it commonly presents with severe retrograde amnesia, with intact insight and rare instances of confabulation. These individuals often present with aphasia as well as agnosia. Another cause for amnesia includes surgical ablation, where medical providers will specifically resect or destroy parts of the brain. Usually this is done to treat other types of conditions like epilepsy. And the areas which contribute to amnesia include bilateral medial temporal lobe damage, including things like the hippocampus, parahippocampal areas, and the amygdala. And this type of damage results in severe anterograde amnesia, so these individuals can't learn new information, but the non-declarative learning is typically intact. A story related to this is patient HM, who underwent a resection of his temporal lobes, including the amygdala and hippocampus, and he presented with this anterograde amnesia. The story goes that one of his doctors went in to talk with HM and had a vibrating shock ring on his hand. So when he shook HM's hand, the ring vibrated and it surprised HM. Afterwards, the doctor left the room, waited a minute or two, and then returned, and because of the anterograde amnesia, HM couldn't remember that he had just seen the doctor, but when the doctor reached for HM's hand, wouldn't shake his hand. And when asked about it, HM wasn't sure why, just that he didn't feel like shaking the doctor's hand. That indicates that some of that non-declarative learning is still intact. Following these types of resections, individuals typically have intact insight and don't often present with confabulation. Another common cause of amnesia is a posterior cerebral artery stroke, and depending on the laterality of the stroke and the areas affected, can alter the specific presentation of amnesia that these individuals will present with. These strokes often involve the medial temporal as well as posterior occipital lobes, and can result in visual deficits such as hemianopic alexia, color agnosia, and object agnosia. Dementias are other disorders that are often associated with memory dysfunction. Particularly Alzheimer's dementia is characterized by poor encoding of information, which limits their ability to recall or be cued to the missed information. There's also other dementias and disorders that disrupt the frontal subcortical systems that contribute to memory, including vascular dementia, multiple sclerosis, Parkinson's disease, and frontal temporal dementia. Frontal subcortical dementias typically display retrieval difficulties, but can benefit from retrieval cueing. The next domain that we'll be discussing is related to executive functioning. This is a multifaceted construct, and it displays significant overlap and coordination with other cognitive abilities, including attention, language, social and emotional functioning, as well as personality. Given the significant overlap, there is some controversy about executive functioning, whether it actually stands up as its own discrete cognitive domain. So executive functioning is thought to enable independent, purposeful action and what's called top-down control of behavior. And it consists of multiple neurological systems and interconnections with cortical and subcortical areas. There's a 3-syndrome model related to executive disruption. So one syndrome is the dorsolateral prefrontal syndrome, also called the dysexecutive syndrome. And this is characterized by poor problem solving, impaired word generation, difficulty with sequencing and organizing information, what's called abulia or amotivation or pseudodepression, and it's a difficulty initiating actions. Individuals with this syndrome typically present with what's called perseveration, where they get stuck on a thought, an idea, and have trouble moving on past it. The second syndrome is orbital frontal syndrome, also known as inferior ventral frontal syndrome. And this is characterized by emotional lability, so emotions rapidly shift with these individuals, disinhibition and impulsivity, childishness, personality change, and distractibility. And the third syndrome is the medial frontal cingulate syndrome, which is characterized by indifference and reduced initiation, amnesia, incontinence, leg weakness, and it can involve supplementary motor area and frontal eye field dysfunction. These upcoming charts highlight some symptoms that are associated with executive dysfunction, outlines what that specific ability is, and what areas of the brain are associated with that specific symptom. So I'm not going to read through all of these, and if you need more time to review the chart, feel free to pause at any given time. For example, disrupted motor sequencing. Motor sequencing is people's ability to perform tasks in a specific order, and that occurs after damage to the prefrontal and dorsal lateral prefrontal areas. Whereas poor directed attention, which is people's ability to allocate and direct attention, that can occur following injury to the prefrontal areas and frontal eye fields. A third example would be poor working memory. Working memory is information that's actively maintained or rehearsed and that can persist for several minutes, and that's associated with the dorsolateral prefrontal area. This chart shows some more abilities. So for example, abulia, which is a lack of initiation, motivation, or concern, and that often shows up following damage to the dorsolateral prefrontal areas or basal ganglia or medial frontal area, particularly within the anterior cingulate. Whereas poor planning and organization is difficulty categorizing information in meaningful ways with prioritization and goal setting. And this deficit is associated with disruption in the dorsolateral prefrontal and orbital frontal areas. Whereas something like impulsivity, which is acting or reacting without careful thought or planning, is more related to the orbital frontal areas. Another important symptom is utilization behavior or environmental dependence, which is also called stimulus-bound behavior, where people will have automatic responses to stimuli or objects that are at hand in an inappropriate situation. So they'll use the object appropriately. So for example, these individuals, if they sit down and there's a cup on the desk, they'll grab the cup in an attempt to take a drink from it, even if it's not their cup. And this utilization behavior typically occurs following orbital frontal and medial frontal injury. Here are some more symptoms associated with executive dysfunction. So once again, I'm not going to go through all of them. I think a few worth highlighting include Witzelsucht, which is inappropriate jocularity and childishness following orbital frontal area injury. Depression often occurs following left frontal lobe injury. Another interesting symptom is this reduplicative paramnesia, which is the feeling that a place has been duplicated, which can present following damage to the right posterior parietal and frontal areas. And somewhat related to that is Capgras syndrome, which is the feeling that a person has been duplicated or is an imposter. So sometimes people will feel like their partner has been replaced by someone else. And that's as a result of right temporal and bilateral frontal lesions. And one of the most common findings following traumatic brain injury is anosognosia, which is lack of awareness of deficits, not due to denial or avoidance. So these individuals don't present as defensive, but they just don't know that there are deficits in their functioning. And this can be caused by diffuse brain injury or focal damage to frontal, posterior, and parietal areas, as well as Wernicke's area and right hemisphere regions. So there's a variety of disorders that are associated with executive dysfunction, including dementia, and it's fairly common in what are called cortical and frontal subcortical dementias. Cortical dementias include frontal temporal dementia and Lewy body dementias, whereas frontal subcortical dementias include things like Parkinson's disease and Huntington's disease. The cortical dementias are much more likely to display the reduplicative paramnesia or Capgras syndrome, whereas the frontal subcortical dementias are more likely to display personality change or depression. Another common cause of executive dysfunction is acquired or traumatic brain injury, and the location of damage can result in dysexecutive symptoms and or personality change. One of the most famous examples is a man named Phineas Gage, who had a railroad spike go through parts of his frontal lobe, and following that injury demonstrated pronounced changes in his personality and behavior. Additionally, with diffuse frontal or diencephalic injuries, you'll find there's a significant decrease in awareness as well as the presence of confabulation. Addiction and impulse control disorders are also thought to be a result of executive dysfunction, and these include things like binge eating disorder and pathological gambling. Many Parkinson's patients receiving dopaminergic treatment demonstrate compulsive repetition. This increase in dopamine appears to be contributing to some of these impulsive behaviors. And it's associated with impairment in the frontal striatal, particularly the subthalamic nucleus, and cingulofrontal connections. Individuals with Willy-Prater syndrome experience hyperactivity of the limbic reward circuitry, particularly within the amygdala, and lowered activation in cortical inhibitory areas. And this contributes to their excessive eating and obesity. So individuals with Willy-Prater syndrome will overeat even after they've reached a point of being excessively full. Focal lesions can also disrupt frontal circuits and contribute to executive dysfunction. So this can include things like brain tumors as well as vascular injuries in specific locations. And that can compromise these frontal systems and lead to this executive dysfunction. The next domain that we're going to discuss is the sensorimotor domain. So these are abilities related to somatosensation and body orientation. Somatosensation is the sensory feedback that you get through your body. And disruption of our sensorimotor functioning can affect our motor abilities. It can result in lateralizing problems in speed and dexterity, so where you're much quicker or more dexterous with one hand versus the other, and the loss of ability to carry out purposeful movement. So this graphic highlights the location of the primary motor area, amongst other areas, as well as the primary somatosensory cortex. And you'll note that they're right beside each other, and they're actually separated by the central sulcus, which separates the frontal lobe, where the primary motor cortex is located, and the parietal lobe, where the somatosensory cortex is located. So these graphics show what are called the motor and sensory homunculi. So along that primary motor and primary sensory areas, we have different amounts of brain tissue dedicated to different parts of our either volitional movement apparatus or sensory apparatus throughout our bodies. And the amount of tissue dedicated to these depends on the amount of neuronal innervation in these different parts of our bodies. To the right, you'll see pictures of what are called homunculi. And these homunculi are representations of how our body is represented based on the amount of brain tissue associated with these different parts of our bodies. So you can see a dramatic representation for our hands, faces, tongues, and lips within these different homunculi. So there are a few disorders associated with sensorimotor dysfunction. So one of these is autotopagnosia, which is the loss of ability to identify parts of one's own body. And subcategories of autotopagnosia include finger agnosia being the loss of ability to name or identify fingers, and that can be on your own body or another person's hand. Right-left disorientation is another type of autotopagnosia, and that's the inability to identify right and left sides of bodies, including your own and others. And these presentations often follow left inferior parietal damage, particularly along the angular gyrus. On this graphic, the highlighted area is the area where the angular gyrus is located. Other disorders associated with sensorimotor dysfunction include somatognosias, and that's a disturbance in recognition of your own body schema. So that's your general feeling related to the existence of your own body. And this can present as a stereognosia, which is the loss of ability to recognize the nature of an object via tactile sensation or physical features, such as size or shape. And this occurs typically unilaterally, and it's associated with posterior parietal or Rolandic gyri lesions. There's also asomatognose, and that's an acquired disturbance in the knowledge or sense of your own body and bodily condition, and that's associated with multiple injury profiles including bilateral parietal lobe lesions, unilateral lesions in the right inferior parietal lobe around the intraparietal sulcus, the supramarginal gyrus, and the angular gyrus, and unilateral lesions of the dominant parietal lobe, particularly near that angular gyrus. Another common sensorimotor disorder is apraxia, which is the impaired ability to carry out previously learned purposeful skilled movements, and this is despite having normal motor abilities and comprehension of the skill. So this is not due to any kind of weakness, incoordination, sensory loss, inattention, comprehension, or intellectual impairment. And it's commonly associated with aphasia as well as anosognosia. And this can be secondary to focal lesions, progressing dementias, as well as stroke. When it comes to evaluating apraxia, it's typically done through having the individual pantomime object usage, testing of what's called transitive or goal-directed movements using an object, as well as intransitive or hand gesture movements without an underlying goal. So an example of a transitive movement would be, show me how you use a hammer. And an example of an intransitive movement would be something like, show me how you would call someone over, or show me how you would signal stop. You can also test apraxia by testing an individual's ability to carry out a series of acts, such as, show me how you would prepare a cup of tea. And apraxia is typically associated with lesions in the left inferior parietal lobule, particularly along sensory areas, as well as the frontal lobe, particularly along the prefrontal and supplementary motor cortices, as well as the corpus callosum, which contributes to communication between the left and right hemispheres. There's a variety of disorders of apraxia. One is apraxia of speech, or the impairment in planning movements necessary for speech production. This isn't considered a language disorder, and it's characterized by inconsistent articulation errors and difficulties with articulatory placement. Apraxia of speech can be developmental or acquired later in life, and when it's developmental or childhood apraxia of speech, these kids are able to accurately pronounce single words or words in series, but have trouble with what's called dysprodic rhythm and poor articulation in conversational speech. So individual words they tend to do fine with, but during conversation they'll have an odd rhythm to the way they're speaking and make a lot of articulatory errors. There's no specific location of anatomical dysfunction that's associated with apraxia of speech. Bucofacial apraxia is difficulty with voluntary skilled movements involving the face, so things like the tongues, lips, and cheeks, and that can be assessed with intransitive gestures, puffing out your cheeks, sticking out your tongue, or transitive facial gestures, including things like pretending to suck on a straw or sniff a flower. Gait apraxia is the loss of ability to use legs appropriately for walking, and that's despite the correct use of legs for walking when lying flat on your back. Ideational apraxia is loss of ability to plan and execute complex gestures, including things like tool usage. So you wouldn't be able to show me how you use a hammer, those kinds of things. And this is considered a motor planning dysfunction, and it's an error in sequencing actions necessary for a task. So if you're asked to make a cup of tea, they'll demonstrate pouring the water in the teacup before heating the water. And this is associated with bilateral but non-focal lesions, but can also include lesions in the posterior temporal parietal junction within the left hemisphere. Another type of apraxia is ideomotor apraxia, which is the loss of ability to perform or pantomime gestures, both transitive and intransitive gestures. That said, spontaneous production of the gestures may be intact, so this loss of ability may only show up when you ask them to specifically perform the gestures. And once again, this is done by having them demonstrate various intransitive as well as transitive limb gestures. And ideomotor apraxia is associated with lesions in the left inferior parietal areas, supplementary motor areas, as well as along the corpus callosum. Another type of apraxia is limb kinetic apraxia, which is the inability to precisely move either your hands or your legs, and this is not related to the person's ability to perform skilled movements. So you don't see deficits in the individual's ability to select or sequence the movements, and you'll see more disruption in transitive movements rather than intransitive gestures. And deficits associated with limb kinetic apraxia are often asymmetrical, with a stronger effect on movements involving the extremities rather than movements along the trunk and core. And it's associated with lesions along the pyramidal motor system, which you can see a representation of the pyramidal tract in a graphic on the right. Agraphia is also considered a sensorimotor disorder, and it's impaired ability to write. And once again, it's associated with aphasia and alexia. And this can be due to disrupted sensory feedback, errors of omission, motor sensory deficits, impaired letter formation, and spatial deficits that are manifest by poor spacing or poor use of space when writing. Gerstmann syndrome is a specific syndrome that combines a lot of these deficits that we've talked about, including finger agnosia, acalculia, left-right disorientation, as well as agraphia. The final cognitive domain we're going to discuss is the emotional and neuropsychiatric domain. Emotional dysregulation and personality change, as discussed before, can be the result of neurological dysfunction or injury. Neuropsychiatric changes can be caused by either the direct impact of neurological dysfunction. So for example, depression is frequently associated with a variety of neurological diseases and disorders and other types of injury, particularly injuries which impact the left hemisphere. Another contributing factor to neuropsychiatric difficulties include emotional adjustment to the current context of the person's life. So for example, individuals can go from a very high functioning independent person to requiring significant amounts of assistance. And just that change in context can contribute significantly to neuropsychiatric symptoms. Additionally, many individuals with chronic psychiatric disorders demonstrate a variety of cognitive deficits in addition to the behavioral and emotional symptoms they display. So the classic example is schizophrenia that can often result in unintelligible speech or a general paucity of speech. There's a variety of neuroanatomical regions and systems that contribute to our overall emotional regulation, including the frontal lobes, particularly the orbital frontal and left frontal areas, the right hemisphere, the limbic areas, including the amygdala and septum, and the cerebellum, which is associated with emotional and affective processing. There are a few common emotional symptoms following brain injury. So one is anosodiaphoria, which is the lack of emotional distress despite awareness of impairments such as paralysis. And that's common following right parietal or frontal system dysfunction. Labile indifference is another set of symptoms that's characterized by a lack of concern about your overall symptoms or disability. Alexithymia is the inability to understand, process, or describe your own emotions. That can occur following dysfunction in the right hemisphere, particularly the amygdala, insula, and fusiform gyrus. Emotional lability, which is increased emotional fluctuation or reactivity, and that's fairly common following disruption to the orbital frontal and limbic areas. Another common neuropsychiatric symptom is rumination, which would be excessively going over a thought or a problem in an unproductive way, and that can be the result of subgenual prefrontal cortex dysfunction. Pseudobulbar affect is a particular emotional symptom wherein there's an extreme involuntary emotional response following mild stimulation. So they'll react with things like excessive laughter or crying following somewhat benign stimuli. And it's associated with pseudobulbar palsy, which includes dysarthria, dysphagia, facial and tongue weakness, and emotional lability. And the pseudobulbar affect is associated with damage to the upper motor neurons along the cortical bulbar tract, as well as cerebellar connections. So if you want to learn more about these various topics and some of the disorders associated with them, you can get more information from, once again, the Clinical Neuropsychology Study Guide and Board Review Guide by Stuckey et al., as well as Blumenfeld's Neuroanatomy through Clinical Cases. Additional information is found in the Little Black Book of Neuropsychology by Schonenberg and Scott, as well as the Textbook of Clinical Neuropsychology by Morgan and Ricker. Other useful books include Clinical Neuropsychology, a Pocket Handbook for Assessment by Parsons and Hemeke, as well as Lazak's Neuropsychological Assessment Book. And for any additional study resources, you can once again go to brainaacn.org, where you can find written and oral exam study groups, mentorship opportunities, mock exams, as well as sample questions, flashcards, and other book recommendations. This has been TLDR Neuropsychology. Please like, subscribe, and comment below. Thanks for your time, and have a great rest of your day.